Three, two, one. The views and opinions expressed in the Love Lounge radio show do not necessarily reflect this listening platform or any other platform that the show is aired on. With that being said, let's talk. From the capital to the continent, if it's in the Black community, it's in the Love Lounge. I'm your host, Jamal DJ One Love Muhammad, and welcome to the Love Lounge. Yes, indeed. Welcome, everybody. Welcome to the Love Lounge. I'm your host, Jamal DJ One Love Muhammad. We just getting to get started. Where are my supermen and superwomen at? This is my joint right here, black coffee. Let this ride out for a little bit. And get ready for another amazing show. March 13th, 2021.
I can't do this anymore.
You could probably get away playing that all night long. That's really cool.
Oh yeah.
I need someone that needs me. Can you be my friend? Can you be my friend?
All right. Like I said, that's Black Coffee. Superman is the song. That's one of my favorite jams, man. Anyway, welcome to the Love Lounge radio show. Your host, DJ One Love. And we're getting started. Today's topic is race, health, and medicine, a Black practitioner's perspective. And for my first hour, the guest is the one and only Dr. Fenwa Milhouse. How you doing, Dr. Milhouse? Give her a hand, everybody. Yes, indeed. So, Dr. Milhouse, please tell the Love Lounge audience out there listening on digital analog radio and on Twitch TV/DJ One Love a little bit about yourself, where you're from, a little bit about your history as far as, education, where you went to school, et cetera, and some of the things you like to do. And then we'll get the show started.
Thank you. I'm so excited to be in the Love Lounge. And I am Fenwa Milhouse, and I am a board certified fellowship trained urologist. And for those who may not know, a urologist is a surgeon, a surgery specialty that focuses on the treatment of diseases that affect the urinary tract. So all the part of the bodies from the kidneys down through the bladder, through the urethra where you pee out of. And also we treat male reproductive issues. And I have been in practice, out of training, and in practice for going on 6 years now. I grew up in Texas, so a little background about me. I am Nigerian born, and my family are immigrants. Me and my family are immigrants, and we immigrated when I was a very small child, about the age of 2, to the United States. We ended up kind of finding our roots in Texas. So I grew up in Texas, and most of the time outside of Dallas, and ended up at the University of Texas, Austin for undergrad. And then after that, I went to University of Texas, Houston for medical school. And then after that, I had enough of Texas. I love Texas, but I needed to see another part of the United States. And so I was fortunate enough to end up at the University of Chicago for residency for urology. And I spent 6 years at the University of Chicago, and I've been in Chicago since then. I never left. So I am fellowship trained as well. That means that beyond urology, I did an extra year in an area called female pelvic medicine and reconstructive surgery. What that is, it's a kind of a further specialty within urology that deals with pelvic floor issues that tend to predominantly affect women, and kind of deals with that aspect. So I now work for the largest private practice group in the state of Illinois as the kind of fellowship trained pelvic floor surgeon in the entire group.
Nice.
Thank you.
And you've also become an Instagram sensation for all the great energy that you have, the colorful clothes that you wear, the dancing that you do. So you're not just a doctor; you're a explosive, energetic human being that gives a lot of light and energy and good vibes to the world. So for that, I appreciate you and thank you for coming on the show. Real quick, I want to say shout out to the Twitch squad. ModX is out there handling everything. So anybody Twitchers out there listening, please post, let us know, share, follow me on Twitch. And if you got any questions, let us know. We're going to open up the phone lines as well in about half an hour, around 8:30, and that's 202-930-3457. Once again, 202-930-3457. So you briefly talked about urology, and I'm glad to have you on because that's something that we, as health as a focus is not a focus as a primary focus for us as Black people, whether it's be born here in America or immigrants coming in, or if you're from the continent of Africa or the Caribbean, UK or Europe, whatever. And I talk about this on my show all the time. Even my slogan is from the capital to the continent. If it's in the Black community, it's in the Love Lounge. And health is something that is still taboo, even in 2021, even in a pandemic. We still have a lot of people that are just, really afraid to talk about health. But when it comes to urology in particular, it touches home to me because my father passed away in 2019. He had an intestinal infection. And so, I learned a lot actually about it because of that. And it was something that related all the way back to when he was a child. He was playing football and he got kicked in the stomach, had a hole in his small intestine and had to get sewed up. And it just, 70 years later, he got an infection from food and stuff that we got in there and everything. And it ended up, the Most High ended up taking his life. But I didn't know anything about it at that time as much as I should have known. So in detail, could you tell me some more information about the study of urology? Because some people really don't totally understand what it is and how it impacts Black people.
Absolutely. I did not know what urology was until I got to medical school. So I don't expect, most people who aren't in medicine to really know what that is. So urology, one of the most common things that we treat is prostate cancer. Okay. So the prostate is a male organ about the size of a walnut that is important for reproductive purposes and is one of the most common cancers in men. I think it's second maybe to longer skin or something like that of all cancers, I think. So we treat prostate cancer. Other common diseases that we treat, kidney stones, also extremely common. Lots of people past kidney stones have dealt with kidney stones. So we treat kidney stones.
Can I ask you something real quick?
Yeah.
Because my mother had kidney stones years ago, like when I was like a young teen. I don't even know if I was a teen yet, but I never understood exactly what is kidney stones. How do you get them?
Yeah, well, stones are basically like aggregates of minerals that form into like a rock type thing. Okay, so we excrete a bunch of minerals and in our urine ordinarily, and if there is an imbalance in some form or fashion that promotes them kind of clumping together, if you will, and coming out of solution. So they're usually in solution. Our solution is urine. Okay. But if there's factors involved that bring them out of the solution and kind of into solid form and clump together, they can form a stone. Stones, most stones start in the kidney, okay? And then stones in the kidney can start to move down the tubes called the ureter. The ureter is the two skinny tubes that connect the kidney to the bladder. Our bladder is what holds urine. And so when that process is happening, when the stones are passing down these skinny tubes from the kidney to the bladder, that can hurt like heck. And you might find yourself in need of a urologist to help you treat the stones. Stones can also form in the bladder too. Kidney stones are more common, but actually stones can just form in the bladder. So some people have bladder stones, and those are a little bit different. But yeah, kidney stones are really common, are more and more common, with every generation. We're seeing patients with kidney stones that are younger. We're seeing a lot more women with kidney stones. So very common thing we have to deal with.
So what are some other urologic issues that we were commonly known to have?
Sorry, I just want to correct. Somebody put out, my Instagram is actually Dr. Milhouse. The first link was correct. The F Milhouse MD is Twitter.
There we go.
Twitter is F Milhouse MD, but Instagram is at Dr. Milhouse. And I am actually also on TikTok at your favorite urologist. So I just wanted to put that out there because I saw that on the screen. Okay, sorry. Say your question again.
Some other common urologic issues that.
Yeah. So another really common issue is leakage of urine or incontinence. So inadvertently, like losing urine. There's tons and millions and billions of people who suffer from what we call overactive bladder, and that's where you suddenly have to go urinate and you can't make it in time, and you might have an accident before you get there, or leak in your pad or whatever underwear before you get there. So that's extremely common. I deal with a lot of incontinence in my practice. Other things that are a little less common, we deal with other cancers in the urinary tract. So there's bladder cancer. Bladder cancer is most commonly associated with smokers. Smokers out there, you are at risk of bladder cancer. So we treat that. We treat testicular cancer. Testicular cancer is less common, particularly in African American population, but we treat that. We treat kidney cancer. We treat even rarer of the cancers. We treat penile cancer. Penile cancer is cancer of the penis, and that is quite rare. So we treat that. What else? As far as in my subspecialty, so I said that I do female pelvic medicine and reconstructive surgery. So I deal with a lot of issues that affect the pelvic floor that are overwhelmingly predominant in women, but not exclusive to women. But one of the common things that I see in my subspecialty is something called prolapse. And prolapse is where particularly after childbirth, but women can be prone to having basically a hernia in their vagina, where things are falling down through their vagina, like their bladder or their uterus is kind of falling out through the vagina. And so I repair that, fix it up, repair those cases. I deal again with a lot of women who suffer from incontinence after childbirth and treat them, and pelvic pain and pelvic floor issues. And I do because I am a female medicine specialist, I do sexual medicine in both men and women. So obviously as a urologist, we treat male issues. I mean, people liken us to like the male gynecologist. So if a man has issues with erections, getting, an erection, or issues with arousal or desire or other sexual things, they'll see a urologist. So I treat that. But then also I do some female sexual dysfunction things as well. So I can treat both.
So what are the most common for women, for Black women? Let me be specific, because I do not apologize for making Black people my priority. So for Black women, what are the more common issues? Because we see a lot of disparities when it comes to Black people. We're almost at the top of every disparity that exists in humankind.
Sure.
But for Black women, what are the more common ones?
The more common urologic issues, probably for Black women, is incontinence, overactive bladder. Okay.
And why is that?
We don't know. We don't. I mean, overactive bladder is extremely pervasive in all demographics. Okay, and young, old. It does tend to be more common as we get older. So older patients are more likely, and of the and Black women tend to be more likely. There's different types of leakages. Okay, there's something called overactive bladder leakage, which I explained is I gotta go really bad.
Mhm.
There's another type of leakage called stress incontinence, and that's when you leak urine if you are doing something that provokes it, like you cough really loud and it leaks out, or you laugh really loud and it leaks out, or you exercise. Black women are more likely to have the overactive bladder leakage than the other type of leakage, stress incontinence. Interestingly enough, we find that Hispanic patients and white patients are more likely to have the stress incontinence leakage more than the overactive bladder leakage. And we don't have an answer why that is. Mm-hmm.
Yeah. Yeah. I see a lot of commercials for overactive bladder medications now. It seems
Mm-hmm.
like I don't know if it's more frequent in recent years, but it seems like it is. Is that the case that it has become more frequent? Or is it
I don't believe it's more frequent. I think people are more open to talking about it with their physicians. In the past, we probably our estimates of overactive bladder are absolutely underestimated, because for every person that's saying I have overactive bladder, I want to get treated, there's probably 3 or 4 people who just never talk about it. Okay, who never bring
right?
it up. And so I think as with time and just being more progressive society and kind of uh, encouraging patients to be unashamed about certain things and talk to their doctors about personal things, patients are just more likely to come forward and seek help.
Right. So what about common issues for Black men, urologic issues that Black men are common to have? Because I'm a Black man, I want to know.
Yeah, you want to know.
Yes.
By
I
and
wanna know.
large, it comes prostate cancer. Prostate cancer disproportionately affects Black men. It's the thing I think about when I see every Black man that walks into my office. You know, what do we have that conversation most likely? Prostate cancer is a cancer that typically occurs in like the mid to later part of your life. Okay, so it's really rare to see prostate cancer in somebody younger than the age of 40, 45. Okay, and so peak decade is like the 5th and 6th decades of life. Okay, prostate cancer is over 2 times more likely in African American men. So 2 times more likely than and compared to white men to have prostate cancer, and about 2 times more likely to have to die of prostate cancer. Okay, almost 2 times more likely to die of prostate cancer. Even when we look at what we call low grade or early stage prostate cancer, so that's the prostate cancer that we catch early enough. Studies have shown Black men are less likely to get definitive treatment for early stage, potentially curable prostate cancer.
Right. Now, are those numbers similar outside of the U.S. for Black men, say in the Caribbean islands or in the continent of Africa, in the African countries?
Yes, the African diaspora. Yes, we see increased risk of prostate cancer.
Okay, so it's not just a Black American thing. All right,
It's not just a Black American thing. Mm-hmm.
right. So, speaking of which, you were talking about the numbers and everything. One of the things that I noticed and one of the main reasons I followed you on Instagram is you have posted a lot of information about racism within the medical field, and we have several doctors on, and I also want to welcome Dr. Dennis Anton, who just jumped on. And racism is one of my top priorities for this show, because I am a study of Dr. Francis Cress Welsing, who wrote the book, The ISIS Papers, and
Mm-hmm.
who teaches the the studying of the system of white supremacy as a systemic issue, not just a hate thing, so that people can understand that it impacts us in every aspect of our life. So when it comes to health, it's kind of been a hush thing that there's a lot of racism in the health field. And when we talk about racism in the health field, it's usually discussed about the patients, but there's also a lot of racism dealing with the practitioners as well that you all face. And I saw some of the things that you posted, and it, eyes lit up, because I'm like, this is a lot of the same stuff that I discuss and a lot of the information that I put out there. But from a practitioner's perspective, what are like the racial disparities that Black people face in America, people as a whole, before we talk about you as a practitioner?
Okay, so like you're talking about the patient side of things, like
the patient side of things first. Yes.
Sorry, hold on, my light just turned off. Oh my God.
I thought we was about to party. I'll keep the music back up.
All right. So I hinted a little bit about I talked about the prostate cancer disparity, but let's just look at kind of the most common ones in medicine that we think of. Black patients in pain are less likely to get offered anything for their pain. So our pain is undertreated. Okay. And that includes children who are in pain. That includes Black children are less likely to receive any painkillers even after surgery. Okay. Wow. So, we're just, less likely to get good pain control. Black mothers, this is a huge one, are 3 times more likely to die in childbirth, even adjusting for income, for access, for education. I'm 3 times more likely to die than my white counterpart, who is are women in medicine, okay? Even as a urologist. Wow. With my 15 years of education and training and advocating for myself, okay? That gets even higher for women who are mothers after the age of 35. Or after the age of 30. So the higher obviously the more advanced the maternal age, the higher overall the risk of carrying a child. But that disparity, that 3 times becomes now 4 or 5 times more likely to die as compared to white women of the same age.
Right.
Metric. Okay. Black infants are the highest risk of dying of all infants in the neonatal period. Okay. There's so many.
There's tons of them. I know, and we could talk about them. Yeah. And any of the other doctors, if you want to chime in, please let me know. But
I'm just going to add that they're less likely to be almost every disease state diagnosed later, less likely to be treated, less likely to be referred to specialists. They just name it. Each additional layer, it's all there.
Yeah, and if I could chime in, what's interesting about it is not only are there disparities, but the care that is delivered, whatever the treatment is very different based on, you can have the same physician who will treat a Black person differently than a white person. And, we used to think, and it's true, that there are access to care issues. We don't get to the clinic in time. We don't have medical insurance, et cetera, et cetera, et cetera. But there have been studies over and over again, and many of these studies are done in the Veterans Administration hospitals. The reason that's important is because if you're a veteran, you get free care. So that normalizes it in the sense that you can't say, well, he doesn't have insurance or he doesn't have access to care. No, he's a veteran. So they go into the veterans hospitals and they look at outcomes. They look at how certain conditions are treated, and they see disparities, which means that these people who have the same access, they should be able to get the same treatments, the same care, and it doesn't matter what the disease is. But the outcomes are different, which means that the medical providers, physicians, nurse practitioners, whoever is delivering the care, is intentionally delivering different levels of care, not always the standard, not always what is the treatment of choice or the treatment that's going to lead to the best outcome to white patients than how they may treat Black or Latino patients.
Wow.
Yes,
Yeah, go ahead.
that is absolutely, you're absolutely correct. And again, as it relates to my field, prostate cancer, we've seen this. Black men are less likely to get offered definitive treatment for early stage prostate cancer that would, be the treatment of choice. They're less likely to get that. So,
Wow.
they get offered that.
Yeah. Yeah, man. I had a question in regards to urology, diabetes. How does that impact any type of urological issues? Because I know I've had type 2 diabetes for about since 2006. And when I first got it, one of the reasons I knew something was wrong is, and it runs in my family. I didn't even know it ran in my family because we don't talk about this stuff. But I found out because I kept having to go to the bathroom. I kept having to urinate. And I was like, what the heck is going on all of a sudden? So, I was like, do I have overactive bladder? There's some type of, bladder issue going on. And I checked myself into a hospital. They pricked my finger and my blood sugar number was like 450. It was like, okay. And that's when I learned about diabetes. But how does that impact your urological issues?
Sure. So actually, the most common theme that we see with diabetic men in urology is erectile dysfunction. Okay. So it affects the blood flow and blood circulation throughout the body. And that includes the microscopic bloods that help get an erection and get blood circulating to the penis. So that's the most common thing. And in fact, when I see any patient with erectile dysfunction, I'm screening and checking for diabetes, period. Less commonly is actually associated with overactive bladder or frequent urination. Everybody always assumes they have diabetes when they start peeing frequently. I find that more people assume, oh my God, I have diabetes. And I'm telling more people, okay, it's not diabetes when they have frequent urination than the opposite. And so, yes, you're right. Diabetes can contribute to frequent urination if it's uncontrolled and glucose is spilling into your urine. But I would say, by and large, what I see most with diabetes is erectile dysfunction.
Okay, yeah, I because I also had the blurry vision that came along, and I was in my mid-30s. I'm like, okay, what the heck is this? And checked myself in the Howard Hospital, and then I called my mom and I told them what happened. She's like, oh yeah, your grandmother has that, and my sister and two of your uncles. I was like, no, I didn't know any of this.
Yeah.
Because we don't talk about health issues, in the Black community. And so
Yeah.
then that's when I started becoming, I took it very serious and got on a very strict diet. I started to lose a lot of weight, exercising, cut out a whole lot of things. And I'm still learning to this point because I see how all of this is tied together. But yeah. So now the racial barriers in the medical field as you as practitioners, can you please expound on that? Because that's deep, and that's something that a lot of people don't really know much about.
Well, yeah, we are at a disadvantage from the beginning. We're working at a starting lineup that's behind our colleagues that are not Black. We oftentimes don't have mentors that look like us. We don't have other people that we know that have been doctors that can help guide us. We are often assumed to be inferior in our performance just by being Black, okay, and kind of evaluated potentially with a lot of bias. We have to watch how we advocate for ourselves, because then there's a double-edged sword. Like, if I'm come off a certain way, am I going to be labeled the problem person and I'm Black? You know what I'm saying? Difficult to work with. I mean, these are things that can show up on your evaluations from other physicians, and you're trying to get into residency, you're trying to get into fellowship, or you're trying to get a job. And these are kind of these words that get used and too often with Black trainees that are problematic. We have also financial barriers too. I mean, medicine and training in medicine can be expensive. So there's financial barriers. And then microaggressions abound. Microaggressions galore. We could spend an hour on microaggressions. You heard. You see my Instagram, yes.
Yes.
I've taken time to talk about that. And will continue to talk about that. I'm actually writing a paper for American Urologic Association, the news that goes out to the entire American Urologic Association, which about microaggressions. So I definitely can talk about that. Yes.
Dr. Ago, you wanted to say something about that?
No, I just needed to show solidarity with my camera on.
I saw you nodding. You were like,
I just had to be there to mention it. I put the question in the chat about any examples or experiences, and I think certainly every one of us can speak about that. But I think particularly in surgery, because surgery is not just white dominated, but it's male dominated. So I wondered if you could talk about any of the experiences that you've had that have been really enlightening and highlighting you like that, enlightening, but highlighted some of those differences in the way you're treated and assumptions. So just be curious from a surgical perspective.
Yes. So double minority. Okay. So I'm a urologist, and just so everybody knows, urology is heavily male dominated. In fact, it's one of the top specialties with the least amount of women representation. I think about 8% of urologists are women. 2% or less are Black, so less than 1% are Black women. When I walk into the room, no one assumes I'm the urologist. They don't even assume I'm the doctor, talk less of the urologist. Okay. So it's sexism, microaggressions, and then there's the racism, anti-Black microaggressions. Okay. And I'm young too. So
and cute, which is no, I'm serious. It's actually
that has something to do with it. Yeah. So cute with lots, Black. I mean, just all of it, right?
Thank you. So some of the examples, egregious examples. Okay, so this is by far one of the most egregious things and I posted on Instagram. As a medical student, I was rotating at a different institution. We do these things called away rotations, where we go to a different institution and we spend a month there. And this is a urology rotation. And I am actively applying to be a urologist. And so on these rotations, you have to be on your best behavior, because you are trying to get into this very competitive field. And urology is a small community. Somebody over in, Dallas can talk to their friend all the way in Seattle, and you or go to LA or Chicago, go back and talk to somebody and say, you know what, she rotated and she had an attitude, she was disrespectful, and ruin your whole thing. So very much a month-long audition, basically. And so I was in the operating room of a well-known surgeon at this away rotation, very prominent white male surgeon, and it was a very busy operating room. There was probably like 7 people in there. There was other nursing staff, there was other residents and fellows, and another visiting med student. And I introduced my name, and at the time I wasn't married, so Fenwa Famakinwa. And he's like, "Where's that from?" And I explained, "Oh, I'm Nigerian by birth, and I was raised in the United States, and it's Nigerian, it's Yoruba." And I'm, eager and happy, and, got to put your face on like I'm happy to be there. And I was. And then he states, "What in the world is wrong with that godforsaken continent, Africa?"
Oh my God. Wow.
Yes.
Wow.
He said that.
Yes. Loud in front of everybody heard. Everybody.
Wow. Oh my God.
Yes. Yes. And so can you imagine, this is an attending. This is some 50-plus-year-old man, who's prominent, and I'm like a 20, I think I was maybe 20, I can't remember, 23, 24, maybe 25 at the time, trying to become what he is.
Right.
You see what I'm saying? In this room full of everybody else was basically white. I think maybe somebody was Asian, but okay. And I'm like basically been denigrated, made to feel like nothing, but then also put on this like like everybody's looking at me like, oh my God, what's going to happen? What is she going to say at the same time?
And what you should have said is it started 500 years
Right.
ago. It's called
Exactly.
colonization. It's called rape, plunder, and pillage. And it's still going on today. And if Europeans and Americans get their greedy hands out of the continent, maybe it can heal itself.
Right.
And she would not be sitting here today.
It would not be-
Right?
I didn't say that was going to get you a promotion. I just said you should have said it.
Actually,
There's consequences for saying things like that. So.
Yeah.
Right. So that's the other thing. You're right. What went through my head was like, okay, how do I respond? But then shoot, I gotta be on my best behavior. So I actually tried to say that message, but in a very whitewashed, like friendly way. Yeah, well, actually, and he cut me off. He didn't want to hear. Like, you don't say that. He wasn't saying that to really get an answer. He was saying that that he knew that I knew that he didn't think, excuse my language, he didn't take two shits of me, where my background was, basically.
Right.
He cut me off and was back to operating. Yeah.
Yeah. Real quick, this is the Love Lounge Radio Show on digitalanalogradio.com and Twitch TV/DJ One Love. I'm your host, DJ One Love, and tonight's topic is race, health, and medicine from a Black practitioner's perspective. And my first guest for hour number one is Dr. Fenwa Milhouse, MD, and she's a urologist. And right now we're talking about racism in the medical field, and in particular from a practitioner's angle and their perspective. Dr. Milhouse, what are some other things that you could talk about, examples of racism? You know, and you posted it, and it became pretty famous. Is the doctor who had developed COVID, and she passed away. But before she passed away, she put the video out there. Could you talk about that some?
Yeah. I believe her name was Dr. Susan Moore, and she was a physician in Indiana at Indiana University. And she got COVID, and she was having a lot of pain. So she was hospitalized, and she was having a lot of pain. She's a physician too, so she's like, you know, kind of informed. All right. So a couple things, they would not treat her pain. Like, she was in pain and asking, I need, something for pain to make your patient shouldn't be suffering, okay, in pain. She would be, begging for them to do something to help her pain. She also explained, like, I think I'm having trouble breathing in this pain. Like, I'm in pain and I'm having trouble breathing. Please, can we get, further testing? They did not want to do imaging. And so she was delayed in getting, like, I think a CT of her chest. They kind of said, well, no, you're breathing just fine. You're talking to us. And so you're breathing just fine. They really did not listen to her. They did not take her seriously. She, to be and this is a physician, and they knew she was a physician, right? And so can you imagine just the even worse, response for somebody who's not informed, who's not a physician? So she took it upon herself with no other mechanisms. She started video vlogging, if you will, her experience, and she reached out to online communities of other physicians to help advocate for herself. There's a huge online group called Physician Mommy Group of, like, gosh, I think maybe 80, 90,000 women physician mothers. And she basically posted on that group, help me, I need, somebody to help me. And you could see, it's so sad because I'm in that group, and you can see in real time her videos when she's alive, like explaining what is happening to her, how they're not paying attention. She's in pain. They're not taking her seriously. She's like, day one, blah, blah, blah. They're doing this. They're not doing this. Day two. She recorded all of that in real time. And so she gets discharged. Exactly. And she complained to them. She told them, and she gets discharged and then gets readmitted within, I think, 24 hours for sure, maybe within 12 hours, to another institution. The other institution she's taken much more seriously, but unfortunately it is too late because you can't clean up somebody else's mess. You can't completely revert. So she passes away.
Crazy. Yeah. Yeah, that made a lot of national attention, and it was crazy because you see in the videos of her, and then to know that she passed away, and us understanding the racism that Black patients experience. But here she is a Black physician and patient, and so she's getting from two different ends, and it was like, what the heck.
If I could just
add on. So I was going to say the statement they even made about her, it was sort of these veiled, that she was difficult and angry and et cetera. And I think
intimidated.
Say it again?
Intimidated.
Exactly. And all she was educated, informed, and was inquiring, right? And so those same things that we say about our patients. Oh, that mom in bed too is difficult. That if a mom who looks different, who's white, who's advocating for suburban kids, says the same thing. Oh, she's a caring mom. The mom who happens to have a hairdo, et cetera, who's Black. Oh, she's difficult. Oh, that mom's kind of angry. And they get different treatment. People are less likely to go in the room, et cetera. And the same thing happened with this doc. I mean, the statement was infuriating.
It was infuriating. I was disgusted. Yes, because it basically confirmed this is the actual bias. So you're telling me a patient who's in pain, who's suffering, who's advocating for themselves is intimidating?
Intimidating, right.
To the point that you wouldn't treat her? I mean,
yeah. This pain.
Real quick, Keith. Stephanie on Twitch wanted to know, was anyone held accountable for her death? Do any of y'all know if anyone was ever held accountable?
So I think in that same statement, they talked about reviewing and we'll make, those sort of, we'll do better as an institution, but then it kind of goes away and then we pivot, there's a storming up the White House or whatever, and then we pivot. Yes. But I don't know that I've seen anything definitive to change what happened. So it stopped being a story, right? So I don't know what the outcome is.
Go ahead, Keith.
Yeah, this pain thing is a really striking disconnect. Because if you look in our communities, many of our communities, we are constantly confronted with pain. If you look at the jobs that we do, someone's a delivery person, they're lifting heavy things, they are doing intensely physical labor, or we have patients who have gotten beaten up, gotten mugged or attacked. Physical assaults, all sorts of things, people, falling down the steps, and just a lot of opportunities where people are put in the way of being physically hurt and need pain. Oftentimes in many of the communities, if you look at the pharmacies, the types of the opiate type drugs that we use to treat pain, the more powerful ones often aren't stocked in some of the pharmacies because there's this fear that pharmacy might be someone might try to break in, steal them or whatever. So even if they have a prescription for something that could adequately control their pain, they may not even be able to get that filled at some of the local pharmacies. So this pain thing just stretches far and wide. Yet when you look at the opioid crisis, and this is something really to think about, because this opioid crisis really changed the mortality statistics in the US. As a result of the opioid crisis, more white men died than Black men for the last few years. Now, I don't know how COVID may have impacted that, but this is the group that has been heavily impacted by the opioid epidemic. And you can look at, misprescribing of opioids and how that could lead to it or whatever the case may be. But then you come to our communities where we need these drugs. We're not addicts. We're just trying to get adequate pain relief, and we can't get it.
So, if Dr. Antoine, if you're on, I would love for you to respond to that.
Yeah, I think it's true that in the years prior to COVID, that there's definitely been more emphasis on the non-communities of color. However, what you also see is with the medications being developed, and a couple of them have been developed where I'm working now. Even when you have the medications like buprenorphine and methadone, what they may be, those aren't prescribed either as the treatment for opioid use disorder. What is happening during COVID, though, is communities of color are being more affected by opioid use, and that's more so coming to light in the past few months. Some of that information just coming out from SAMHSA and other areas. So I'd say that, there's going to be a little bit more focus of communities of color, and especially Black persons for opioid use disorder. But that lag is still there. That what we call health discrepancy is still there, and there are a lot of barriers that are getting in the way for treatment, including people just not being prescribed the medication.
Real quick, Dr. Antoine, could you tell people your background as far as what you specialize in?
No problem. Howard alum for School of Medicine, but I work at Johns Hopkins, and I'm the director of the Center for Addiction and Pregnancy, also the Addiction Treatment Services Program, and also the Cornerstone Clinic at Helping Up Mission. So my area is really looking at substance use and mental health for underserved populations. But I'd say 50 to 60% of the folks that I deal with are Black, and many of whom have different barriers that I work with to make sure that they get equitable treatment.
And what are the common or most alarming disparities racially that you see in your field?
Racially, I would see just access to the standard care. And what I've seen mostly through COVID is a technology barrier, because that's been a big thing that's made access difficult for even things like COVID vaccines and telehealth, which is really boomed during this time. But I have a lot of patients and clients that just can't get to that. And I call it the digital divide or digital fitness, however you say it, but access is just one of those things. So that's one of the little less focused on barriers. But then there are other things of providers who have cultural competence and understanding of what the situations are, and even that willingness to empathize into other person's situations, finding that person to make a comfortable environment so you can, at least for me as a psychiatrist, have a comfortable environment to open up and give all the details in order to get the proper treatment. That environment is very rare. So that's another barrier that I see.
Dr. Milhouse, you want to respond to that, please?
No, I'm shaking my head because of the digital divide. And I work, again, for the largest private practice in the state of Illinois. So we are doing a ton of vaccines. And as I quickly realized, these vaccines are not effectively getting to the people of color, the people who need it most, the most high risk. They're not getting to our Black and brown patients who we serve. And part of the reason is this digital device. In order to get the alert that there was a vaccine available, you had to be on my chart. Okay. Mm-hmm. All right. You have to have my chart. And the digital divide absolutely is racially and also age-wise too. And so it's not getting to the highest risk people, okay? And then to schedule your vaccine, you had to be through my chart. Everything had to be through this electronic thing. And so we brought that up. I'm in our diversity, inclusion, equity committee, and we brought that up as, okay, wait, this is a problem that we have to address. And so we're doing more ways of access to get patients to get the vaccine without having that. And we are incorporating ethnicity in the risk, stratification of who can get the vaccine. So, it's not just age or comorbidities, but, race is also being used as a risk factor.
Yeah. Dr. Agu, and you specialize in infectious diseases. Are you seeing the same issue in your field?
So yes, I'm an ID doc at Hopkins, and I run the HIV program there. And absolutely, I think certainly we've seen racial disparities in terms of distribution. The same thing, we have my chart, and you have to have been registered to my chart to be able to do this. Even state of Maryland, you have to be able to have a computer or a smartphone or something to be able to then register to get the alerts to go get your vaccination. Or you have a phone call process, which is terrible, and nobody's using that. So I think we're seeing that. I sit on the HIV Medicine Association board and have talked about these issues. And people are patting themselves on the back in terms of, we have developed a vaccine center, at this place, off the bus line, off the train line. And then so we're patting ourselves on the back for creating systems that actually further create disparities, and so have been really vocal about that. So I think certainly I worry as we open up the vaccine to everybody, like, oh, everybody who's eligible to get them should have gotten them already. And so now we're moving down and we're seeing 10 to 1, 20 to 1, places that normally have all Black patients. Now the lobbies are full of all white patients, right? And nobody's looking and saying there's a problem here. And so, seeing the same thing. And I think also the thing to mention in terms of disparities, the COVID disparities have further exacerbated the disparities we're seeing in other conditions, right? Because Black people are more likely to be impacted by COVID, then less likely to go into care for other things. And we're seeing, again, further divides.
No, I was going to say, even my producer, DJ Jimmy Fingers, said he had to schedule his dad's vaccination for him. It could only be done online, no phone service for scheduling until last week. So, that's a big issue we're having here, especially with COVID. Dr. Crawford, are you seeing a digital divide in your specialty?
Yeah, absolutely. Now, I'm a little different right now. I'm at the National Institutes of Health and overseeing HIV research, but I've got my membership with the Johns Hopkins group. And of course, Allison and I go way back, and Allison is one of our lead researchers. And we should probably talk some about that before we finish. The importance of research and the importance of Black researchers doing this research, because if all of these disparities that we talk about, doesn't matter what specialty you're in, psychiatry, urology, whatever, all these disparities, we have to get engaged in the research. And unfortunately, Black doctors are not so much interested in doing the research, but they could have a key role in recruiting. But these divides are quite profound, just to follow the example that the others have talked about, just the registration for COVID. If you look at the process in DC, very similar to what Allison described. Now, DC does have a call-in number. You can call in and try to get registered. Good luck. Good luck with that. Okay, those lines are going to get tied up. There are ways that you could work with the churches to connect people to come in. There are community centers. There are ways that you could get the vaccines into the arms of the most vulnerable people. But again, the people are not connected and they're not getting the information. So that is definitely a problem.
Yeah. My moderator, Modex, says she works for a digital department of a Fortune 500 pharmacy, very close to the office of the CEO. And the stories that she hears from the company to the common man are night and day in the difference. And she says it's sickening. Dr. Milhouse, have we seen any improvements with the racial disparities in recent years? Let's say in the past 5 to 10 years, when it comes to medication and medicine in the medical field, I should say. Have we seen any improvements from, back in the days? Because we have a history as Black people of fearing, the medical field, and rightfully so. I have the book Medical Apartheid. I read that years ago, and of course we all know about Tuskegee and Henrietta Lacks and a lot of other things. But have we seen in recent times any improvement, especially with the hiring of more Black doctors and practitioners, and any dealing with the patients?
No, because none of those things have actually changed.
There we go.
No. Okay. So first of all, where are all these Black practitioners and providers?
Right.
It's still about 5 to 6%. Okay. So this is a long process. No, we have not seen changes. The changes in the maternal disparity has not changed. The prostate cancer disparities have not changed. Other things have not changed. The biggest thing I think I just want to state this. The biggest thing that public health specialists have found that affects disparities is structural racism. Racism, not our race, is the risk factor. Okay. And so it's structural racism is that compounded multi-institutional racism, whether it's legal and a lot of it is just subversive. Okay. It's not legal anymore because we've, gone through civil rights and all that good stuff. But it persists. These policies and procedures persist to disparage Black people on every level. And that affects how we live, okay? It affects how we're born, where we work, where we get educated and go to school, how we get to point A to point B, what's in our environment, as far as like pollutants and toxins. It's been shown Black people are probably 2.5 times more likely to live in a more closer to toxic environment or toxic pollutants. It affects how our access to medicine, into information, into healthcare. And so that social determinants of health, which is impacted by structural racism and that divide, is the single most influential factor perpetuating these disparities.
Okay.
And if I could jump in, the NIH, interestingly, and I've gotten pulled into this, when you're a Black face and they start talking about disparities, you get automatically assigned to these committees.
That Black tax is real.
But then there are all of these initiatives that are supposed to target, structural racism. When you look at health disparities, and this is what I told my boss, who is and Allison knows all the people in our group. We're in the Division of AIDS. I'm in the therapeutic research program. So our focus is on therapeutics, new drugs, new broadly neutralizing antibodies, other types of treatments, and possible cure for HIV, but other infectious disease. And we've done lots of COVID work. But, the response that I have when you talk about structural racism, and then you talk about health disparities, you're like, okay, we don't have equality in education. I'm living in substandard housing. I'm making the minimum wage. And you expect me to have perfect health?
Right. Yeah.
That doesn't even make any sense. When you look at all of the areas, look at the criminal justice system, look at the educational system, look at employment, look at housing. And when you look at all those disparities, it wouldn't even make sense that people would have in that situation would have good health.
Yeah.
But nevertheless, there are these initiatives that are coming out that are focusing on structural racism. And so they sent our division basically what we call RFA, which is a request for application. So we're asking researchers to help us out with this. And we had a big meeting. I really applaud my boss. Again, he's an Asian American. And he understands racism, probably not to the same degree that I do, but he really had some very strong opinions about it. And so we wrote back and we responded and we said, look, you're not going to come up with some funding announcement that's going to end structural racism. That ain't happening. Yeah. Now, what you can think about is what are some policies or what are some strategies that can mitigate or kind of balance out some of the impact that structural racism may have on certain communities. Yeah. But you can't take a system that's been developed to perfection over 400 years and release an RFA that's going to reverse it. It's doing what it's supposed to do. We're not supposed to have good health in this system the way it was created.
Absolutely. Now, Dr. Milhouse, I have you one more question for you because I know you got to get ready to go. And it's relative to what we were just talking about. But what can we do as a community, including you and all the practitioners and people like myself, and I think I'm doing this by having this show. What can we do to improve the relationship between Black people in the medical field? Because we see the fear is real, and then COVID has only amplified that fear. I got my first shot last Thursday, and I'm waiting until April 1st to get my second one. But I've been advocating for more Black people to just do routine checkups, to go to Black doctors like I do. I request Black doctors because I've had experiences that were different when I had white doctors, especially with my diabetes. But what can we do to improve the trust between Black people and the medical field? And then we have to bring in our next guest.
Yeah, so this is the burden is on the medical field. Okay, the patients are not the ones at the burden. Okay, we have a lot of work to do. The one thing I would have for a patient advice is just to advocate for yourself. Do not be afraid to speak up for yourself. Do not be afraid to ask questions. If you do not understand what's happening to your body, what's being recommended, please say, I need to understand. You need to make sure whoever's treating you, that you understand what's going on. Okay. Studies have shown Black patients have better outcomes with Black providers, probably because there's a better connection and relationship, and they feel more understood and heard and all of these things, and more respected. So, hey, if you can find a Black specialist or doctor to take care of you as a Black patient, at right now, I would say that's probably for your best interest. Ideally, in a perfect world, that shouldn't be that case. And so medicine needs to wake up. That should not be the case. We need to educate our physicians drastically. Okay, we have run amok of just implicit bias, and we don't we have very untrained physicians when it comes to cultural competency. And I'm not just talking towards the Black community and Black patients, but even patients of different religion, even patients that don't speak our language, even patients of different sexual orientation. We have no training to deal with that. Okay. And so we are going to continue to be a disservice to those patient populations. We need to be transparent in these processes that are happening. We need to be transparent so patients feel more comfortable. There's a big mistrust, right, that you alluded to. So we have to be transparent. The vaccine thing, we have to be transparent. Part of the thing when I'm a big, I want all my people to get vaccinated. But the one thing I do not do is preach it and make a Black, I'm talking to a Black patient who's like, I don't want to do it because I don't trust it.
Mm-hmm.
You need to validate that. You need to validate, listen, right, and validate that and understand that. And then try to connect to the patient and say, okay, well, let's talk about some of the fears. Talk to you about that. What is it exactly? And respond back with science and evidence, and hopefully you've turned that patient into maybe considering the vaccine. That's just an example that we can help. Okay.
Well, I really appreciate you. Everybody give Dr. Milhouse a big hand. I appreciate you coming on and sharing your wealth of knowledge, and I appreciate the work that you do, and I'm going to continue following and supporting you. Real quick, how can people, if they want to follow you or have any questions or anything, want to reach you, how can they reach you?
First of all, this has been a lot of fun. So thank you. Thank you so much. I'm in my office, but I've had a lot of fun. You can reach me at Instagram. That's where I'm most live, and you see most of my content. So I'm on Instagram at Dr. Milhouse, and Milhouse is with one L. So at DRMILHOUSE. I'm also on TikTok, if you like TikTok, at Your Favorite Urologist, just like it sounds. It's all spelled at Your Favorite Urologist. And I'm on Twitter, although I'm least active on Twitter of the three platforms, but I'm on Twitter at FMilhouseMD. All
right, appreciate it. Once again, thank you, and we'll stay in contact, because it looks like what I'm going to have to plan is another show with a group of doctors and practitioners and people in the medical field, in all the different aspects of the medical field, because this is something that we're just scratching the surface on this particular conversation, without a doubt. So be on the lookout for that, and enjoy the rest of your day and keep doing the great work. And we're going to move on to my next guest, Anna. Now, Anna, I actually asked you correctly how to pronounce your last name, and I don't like balling it up online. So, Anna, could you please introduce yourself and tell everybody a little bit about yourself in the work that you do?
Yes. Hello, hello, hello. My name is Anna Moukouri Kouoh. I used to be Anna Bo. It was so much easier. Just call me Anna Bo.
Okay. All
I
right.
got married and everything got messed up. Look at what I ended up with. And now nobody can find me in our system. No one can pronounce the name.
Well,
But it's
hopefully we can fix that with this show's broadcast. But tell everybody a little bit about yourself. Where you from? Your educational background and the work you're doing.
yes, yes. I was born and raised in Cameroon, West Africa.
Woohoo! From fellow Cameroonian.
Yes, born and raised there. I moved to the U.S. when I was about 13, and I've been in Maryland since I moved. Then I went to college. I got my BSN from Shepherd University, which is in West Virginia. We're talking about Black practitioners or Black people being in predominantly white environments. I was the only Black kid from my program, at least for that cohort that graduated as nurses. I was the only Black kid there. There might have been somebody else, like a mixed girl. I don't remember, but I was the only one. After I graduated as a nurse, I did a little bit of home health in West Virginia, and then I got a sweet opportunity to come work at Johns Hopkins in psychiatry. And the psychiatry unit that I came to work, I was very specialized. We took care of chronic pain patients and geriatric patients with movement disorders and some of your mood disorders, but primarily movement disorders, and then dementia patients. And after a few years, I went back to school and I thought maybe let me broaden my horizon a little bit. Instead of only psychiatry, let me get certified in something general. So I went to Simmons College in Boston, and I got certified as a family nurse practitioner.
Mm-hmm.
But after I got certified as that, I didn't necessarily go into family practice. I stayed with psychiatry. And while I was working as a nurse, I did a little bit of like rehab center, a little bit of rehab medicine, but that was very brief. And then I went on to go work with Dr. Agu and her and her people in infectious disease. So I provide primarily mental health services to our Baltimore counties and a clinic called the Bartlett Clinic, where we provide services to our infectious disease patients. So it could be HIV, hepatitis, patients who are just on PrEP.
Mm-hmm.
Yeah, and I've been there for the last 2 years. So I'm a new provider in this.
Great.
Yeah.
So we have you on because we're going to talk about burnout. And this is I cannot tell you how timely this conversation is because the conversation came up. One of my producers, DJ Black, still talked about burnout recently last week on Facebook, and he just talked about what a lot of people have been talking about, especially with COVID, but then just Black life and period. How we get burnt out, and I would say, man, it's funny you posted that because this coming Tuesday, that's the second hour's topic, is we're going to be talking about burnout. And by the way, I don't know if you met Dr. Antoine, who's also at Hopkins as well.
You're muted.
You're muted, Mike.
Yep, muted.
Sorry.
There we go.
I attended a talk Dr. Antoine did. I believe it was on, if I'm not mistaken, mental health in the Black community.
Yep. Yeah. I think that was it. And I actually used to work in the Bartlett Clinic when it was in its old name. So
The Moore Clinic.
We'll talk about it a little bit.
The reunion.
Yeah,
That's great. That's what we all about. I'm all about the community. So hey. So Anna, and I'm glad the others are on here because this is a community think tank. That's what I'd like to talk about, or to describe my show. But real quick, because you did I believe it was a write-up on burnout.
I
And
did.
yeah,
So when I first did the presentation, it was we did just burnout in healthcare
uh-huh,
and what that looked like prior to COVID and what it looks like right now, and then some of the resources that or how you can assess it, and then the resources to combat it. So
right.
this isn't going to be
Yeah, I
exactly
got
that.
it.
We'll just touch a little bit on on those things. But yeah, I did.
So, real quick to the audience out there, this is the Love Lounge Radio Show on digitalanalogradio.com and Twitch TV/DJ One Love. I put out on the digitalanalogradio.com website, there's a link that you can do a burnout test that I got approved from Anna earlier today. And then, and anybody, if you're listening or on the Twitch squad right now, if you go to the homepage of digitalanalog.com, go real quick and check it out. It was let me see here. It was the check yourself burnout test from www.mindtools.com. And it's real quick. It's 15 questions that you answer, and then it'll give you a score. And my
Let me
score,
put the link in the
In the
chat.
chat. Mhm.
yeah.
See,
And
one
my
love
my
just
score, I did my score. I came out with a 42. So I was like, hey, you got to watch it because you could be at risk for burnout. But I would love to hear what anybody else if they want to tell what their score was as well out there before we actually go into actually what burnout is. Um, or you can post it and then we'll talk about it in the meantime. There's the link out there in the chat for those on the stage, as I will call it. Um, so
What was
real
your
quick,
score?
my score was a 42.
Okay. You were
Yeah, so
close. You were
I'm
close.
close, yeah. And I mean, I'm just close because I'm black. I mean, that put me in a at-risk category because I'm a black man. I work for myself. I'm trying to help to fight against racism. I'm trying to help fight against classism and sexism and uniting black people. And so that in alone, it is, and I'm a DJ, you know. So yeah, I scored a
No days
42.
off. No
No,
days
no days
off.
off. No, no days off as an activist because the enemy doesn't stop, so we can't stop either. Uh, Real quick, Anna, describe what burnout is.
Oh yeah. So before we even get into what burnout is, like we've all been in a year that's a storm essentially. But although, and although we've weathered the storm together, depending on the resources that you have or have access to, as we've talked previous, and with our previous guests, depending on what resources patients have, the consequences of COVID have looked completely different to all of us, to our patients, depending on family. And so the burden of disease and its impact has been extremely severe in our community of color, as we've talked about. And so burnout has been getting more and more. It's not a new topic. It's just been getting more and more traction because of what we're seeing to be the potential lasting effects on our population's mental health. And so this traction towards the phenomenon of burnout really started back in between April and June last year, when we started seeing reports come out from China about how because of the frontline workers, they were hit first with COVID. And so we're seeing reports about how the frontline workers were reacting to everything that was going on. And that's how we really started looking at burnout. But before we go in and really define what burnout is, because it can sometimes be confused as just stress. It can sometimes be confused as just stress, or the two being used interchangeably. So stress being used as burnout and burnout being used as stress. Stress, as you know, it's usually just based on a particular event. Once that event happens, your stress goes away, right? And it can be positive or negative, and it can be a motivator. But burnout, on the other hand, I'll give you a little background. The first time the phenomenon burnout really came about was in the 1970s, and it was named by Dr. Fruitenberger. He worked in New York, and he was at a free clinic that saw patients who dealt with a lot of substance use. And he was seeing his staff coming out with symptoms like they were just depleted, and they were starting to be really frustrated, really cynical with each other, and just not providing the best care. And at that time, he named the phenomenon burnout. And it's essentially continued experience of stress for a prolonged period of time. What that gives, that I ask it, is a constant demand on your sympathetic nervous system to constantly be in that fight or flight, right? So your sympathetic nervous system is what gets you through. Oh, a bear is about to claw me. Let me run, right? So you release of cortisol, all that stuff. Your adrenaline is going, blood flow is going to important organs and all that stuff. So burnout is essentially you're functioning at that state of mind, state of body all the time, that you start to come up with these symptoms, where a cascade of symptoms, which we'll talk about later.
All right. So several people have posted their scores. I'm going to read them. Dr. Antoine got a 32, which is dude,
you're good.
You just
you're good.
Cool. You cool like that. Let's see. Dr. Agu got a 46. So that's where we at.
Be careful.
Yeah, be careful.
The 39 to 40, 33 to 49. That was the be careful. Once you got to the 50s, that was where you were at. You're at a severe risk of burnout. Do something about this urgently.
Yeah. So in the Twitch squad, Stephanie got a 34. So that kind of makes sense, because she just laid back like that, you know. So and she just a nice calm person. Now Black Steel, who was the one who put it out there, one of my producers and one of my brothers from another, who's also co-owner of this radio station, DJ Black Steel, he got a 56. Let's talk about that.
I want to hear. I want to hear at least one of the symptoms that he had, because I think that's what we're going into next. Symptoms of burnout.
Black Steel, if you want to, you can say it if you want to, or we can.
You don't have to.
Oh, it's all good. I'm not turning my camera. I didn't turn no lights on.
No, it's all good.
But yeah, I mean, there's everything from lack of appreciation to being pulled from every angle, knowing that you're at the center, and no matter what happens, you know that no matter how you feel about it, it has to be done. So it's just one of those things where I no longer frown about it. I don't pout, kick, cry, roll across my carpet. I just pretty much get a straight look on my face and do what has to be done, but I'm just tired of doing what has to be done.
Yeah. You're depleted. Your energy is depleted. Yeah. And so
he's also a father, a young Black boy, amazing young Black boy, but he's raising him. So that's a whole nother category of work that, and responsibilities on top of it. Mm-hmm. So go ahead, Anna.
When we're looking at the symptoms, the symptoms of whatever, maybe stress, burnout, can tend to overlap with those of things like depression and anxiety. I'm aware that today's show is focused on a Black practitioner's perspective, and I wouldn't be doing any service, in presenting without bringing to attention the fact that we as a Black community have so many barriers, as we mentioned earlier, barriers to care, whether it be that willingness or that access to the care, misinformation, under or over diagnosing, and or under or over medicating, the stigma that we talked about, and many other things. And I bring these things because symptoms of burnout, again, they overlap and can lead to people not seeking out care because they're thinking about the bias or how they're going to get, how the public or private stigma that they're going to get if they seek out help. So if you think about burnout, you categorize the symptom. I mean, the symptoms by physical, emotional, and behavioral symptoms. Under your physical symptoms, of course, you have sleep issues. People are going to have headaches. You're going to have weight loss, weight gain, which are all symptoms of could be all symptoms of depression. You're going to get people who are constantly sick just because they're not giving their immune system time to rest and reset. Blood, we're talking about blood problems. Hypertension being such a prominent problem. And then you're adding constant stress on top of that. You get people who have blood pressures that are medicines aren't doing anything to help them. And then you get like your short attention spans. Imagine with our parents who we've talked about who have young kids who are now dealing with their attention span because they're burnt out at work, and then having to come and deal with kids who've been at home all day long, and they're having to deal with all that. And then you have your emotional stuff, feeling angry, like I just don't have it anymore in me. You're less empathetic towards your peers, your family, your friends. And then there's a loss of motivation just to get your work done. You're irritable easily. You get pessimistic. You just don't have any more. Like, my cup is empty. I don't have any more in the cup to pour for you. And then you get your behavioral symptoms. So now productivity starts to become an issue. You're running away from responsibility. You take frustration out on other people. You get rude. You stop even trying to reach your goals that you may have set for yourself. You stop trying to go that far into reaching them.
Right. Now, my moderator, Mod X, she scored a 71. Yeah. Wow. Yeah. So let's talk about that. And let me put it out there. I let her know how much I love and appreciate her all the time. Because she's handling our the moderator of our Twitch squad and all the comments and everything. And I tip her and everything, and I let her know, yo, I really appreciate you, Queen. But she's also a mother, and she also has a day job and so forth. So let's talk about her situation.
Okay. Well, tell me how you're feeling about it. Moderate. What's your name?
It's Trina, but we
Trina.
go by Mod X.
Okay. Tell me how you're feeling about it.
See what she says, because
the reason we wanted for people to
she escalations in her department. So I've worked in escalations. Woo! Yeah.
Oh man.
So when all the problems aren't getting solved, then you got to go to her and take it to the next level. So that's one of the issues right there in itself. But the
reason we wanted to have people do the questionnaire is sometimes you might not even be thinking about it as burnout. You're thinking about it as in it's part of the job. At this point, it's part of the job. And the issue is where you're gonna get to a point where you no longer have the best picture I've seen to explain burnout is there's a picture of, I don't know what the guy's name is. So the guy is there, Andrew or whatever his name is. And it's that picture is talking about stress. Andrew is stressed out, blah, blah, blah. And then the next picture is just an empty frame. There's no Andrew in it. And that's the burnout. That's the burnout illustration. So you get to a point where you're just not there, right? We don't want people to get to, well, this is just part of my job. I got to do what I got to do to make it to tomorrow, right? It's just part of life. Stress is part of life. This is part of what I have to do to make do. We don't want to get to that point because a lot of times people don't identify it as burnout. They look at it as it's just part of work.
So she also has her own business, and she says that it's just her life. She's come to adapt, which is kind of what you were just talking about.
Yeah.
I want to welcome Denise McNeil. She's representing P&G. What is it? P&G Counseling. So she joined in.
Services.
Yes. So, but yeah, we're talking about burnout. And Dr. Antoine, what do you do when it comes to dealing with patients who are suffering from burnout?
You're muted.
Still can't hear you. Is,
He said he's gonna get off and come back on.
Yeah.
okay. Oh, he's gonna get off, come back on. All right.
Yeah.
Uh, and if a patient comes to you,
Mhm.
like let's say Mardex, she comes to you. She's got a 71. You know, she's a mother. She works. She has her own business. She's dealing with life as a Black woman, and she comes to you with this score. What next?
We need to start talking about the resources that she has in her life that she needs to make use of, right? Because uh, I want to play Superwoman a lot of the times. I want to be able to wake up in the morning, feed my kid, take them to wherever I need to take them, be at work on time, see every single patient that I have scheduled for the day, and make sure that they get whatever they need, make sure that I'm doing all the administrative stuff, and then come home and do that all over, right? We tend to forget, of course not intentionally, forget about the resources that we have in our lives. That might be a friend who could watch your kid. That could be you delegating part of your work to your team members. I'm gonna start to make sure that they look at the resources that they have in their life and make sure that they're making use of them.
Okay. Real quick, I want to say what's up to Michael Bruins. Give me a beat. Good to see you, brother. Always glad to have you participating. He just joined in on the Twitch. Dr. Anton, are you there now? Can we hear you?
Yeah, I'm in. Can you hear me okay now?
Yes,
Yes.
we can.
All right.
So when they come to you, or you deal with these situations, because you deal with some type of, intense situations, basically being up there in Baltimore and then in the field that you're working in specifically, how do you handle it?
I mean, the first thing I do is I make sure that the person's comfortable in talking about the situations that they're in, because I think a lot of the times the practitioners they may deal with, regardless of the background, they might just jump to, this is what I want to give you, whether it's medication or whatever it may be. And I want to make sure they're comfortable telling their whole story. I've been more and more using the analogy of Bob Ross, the painter on TV. Like, I'm just going to jump around and get all this sketch on the canvas. But if I don't understand what's on the canvas, I'm not going to do a good job of telling you what might be helpful. So that's the most important thing. And I think if anyone is trying to get help and they don't feel that comfort, that might not be the best place for you. So that's the first place I would start. But then from there, I think the Superwoman phenomenon is mirrored by the John Henryism phenomenon that's been known about for decades, if not centuries. And that's something I just make sure people know the difference between want versus need. And oftentimes people want to do a lot of things, but some of those things might not be things they need to do. And knowing the difference between the two can make a huge difference on how you prioritize or how one prioritizes their energy. I'd love to do these things every single day during the week, but I don't need to, and I can't because I would lose sleep. But on special occasions like this, I'll pop out every once in a while and do things like that. So I think that's one of the things, some of the elements that I start to poke out in the first sessions. But just like with that canvas analogy, I try to get more coats and get more ideas as things progress.
Yeah,
Right.
and figuring out what help looks like for them, because what you might consider help or helping that patient isn't what they consider help.
Yeah. Now, Black Steel, he was elaborating more on his circumstance. He's saying the DJ frustration, which I know wholeheartedly about, the day job frustration, parenting frustration, co-parenting frustration, demands on him from his world, etc. But he also said, and I want him to explain this. He said, what makes his even tighter is the fact that he doesn't give people something that doesn't belong to them. I, Black Steel, if you could explain that a little bit more, because that's pretty deep.
Sure. Like the short version of it is, and I think I just typed it as you was asking me. Like the average person, if they're like upset or frustrated, they lash out at the person that's nearest to them in proximity at that particular moment. I'm not one of those people. You know what I mean? If I'm upset at you, I'm not gonna bark at Jimmy Fingers. You know what I'm
Okay.
saying? If I'm upset with you, it'll come out when I speak to you. You know what I mean? So I'm very focused in that manner. But the problem is the longer that type of thing sits and festers, you know what I mean? It has a debilitating effect until you can release. So that was
Okay.
where I was getting at.
Okay. Understood. Now I got a question, Anna. And this I think um others can chime in on this that are here on this panel. What is the impact of burnout in the medical profession? So you all as practitioners working in the medical field, whether it be in the doctors or nurse practitioners or working in mental health, working in administrative positions and everything. But the mental health, often me doing a lot of the work that I've done, I've often had to tell others that are mental health professionals, not mental health professionals, but medical professionals, take a break, because even you see it on TV, shows ER or whatever. Like it can be very stressful. But what are the impacts of that when you all have burnout? Because I was just talking to Denise earlier, and we talk about the stresses on jobs all the time, and especially when you are passionate about your work and you want to do the best and improve the circumstances or help the people around you.
So when I think about medicine in general, I'm thinking about poor outcomes for patients. That's the first thing that I'm thinking about, right? Because if you don't present at your best, your patient cannot get the best of you, right? So we have a in the Black community where we already have patients who don't get the best care. They don't have access to the best care. They may not even seek that care. And then when they come to you and you're burnt out and you're giving them subpar of what it is that you can potentially provide for them, right? So patient outcome is at a loss just to start off, right?
Mm-hmm.
And then there is the previous person who just mentioned lashing out, right? So you have a hostile work environment. We talked about the microaggressions, right? Sometimes those microaggressions maybe not coming from our white peers or our higher ups who may consider us less than them. Mm-hmm. It might come from you to your peers because you're frustrated and you're burnt out, right? And you may not even notice that you're doing so. And then there is, because you're giving so much at work, you give less to during your extracurricular activity. So you give less to your family, you give less to your friends. There's the financial burden of it. You're spending. It could be you're at a position where you're not making as much as you feel you should be making, or you're not being valued the way you feel you should be valued, right? So there's that aspect of it. But the biggest one that I tend to think of is patient outcomes, patient care, and the fact that your patients get less of you than they would have if you're in a better mental, physical space.
Okay. Denise, tell people a little bit about P&G and what they provide.
Oh, hello, everybody. I'm just getting in. I'm sorry I'm late, guys. So I'm the Chief of Staff for P&G Behavioral Health Services, which is located in Washington, D.C. on Rhode Island Avenue, 2218 Rhode Island Avenue. And we provide, we're contracted with the Department of Behavioral Health. So we're considered a core service agency, and we provide behavioral health services to DC's chronically mentally ill. And the 4 services we provide are diagnostic and assessments, medication somatic treatment, community support, housing supports, and therapy. And I want to just put it out there that we are hiring therapists. If you know anybody that wants to do therapy that has a DC license, please send them my way. Jamel can give you my contact information, or I can give that to you. So I pretty much, we went from having 60, they're called consumers. I don't like that name, but that's what DBH calls them. So they're called consumers, clients, patients. It's the same thing. We started with 60. We've been open since October 2019. But I've been with a company called P&G Counseling and Educational Institute, which is the owner of that business actually started a second business of which I used to be part owner. So it's actually two different businesses in the same building. It's a little confusing, but we had an investor come in, and that's how we started the core service agency, and he didn't want to mix the money. So we created two separate companies with very, very similar names. So anyway, but it's quite stressful because we have about 33 community support workers, and they literally get paid to be in the field 50% or more of the time. Now it's COVID, so it's really 100% of the time now, dealing with the consumers at their homes, at the shelters, and the street, and so on and so forth. And I mean, you're talking, I'm not a therapist, I'm administration overseeing everybody. And the stress at my level of just running the business is quite amazing. It is the most, I don't know, I got cussed out twice today on my way to work. I spoke with a consumer like Friday. She called me and she's like, complaining about her situation and everything. So the first thing I do is I go to the system, I start looking up. But once it gets to my level, when you talk about, investigations, I'm not really in investigations, but I'm HR. I'm chief of staff at HR. So it's the same thing, investigations, call it what you want. Once it gets to my level, I have to fix it. There's no choice. I have no option but to fix it. They say, I'm leaving the organization, and they came to me. I have to find a way to keep them. So I have to stop everything I'm doing to address that. So she calls me this morning. The phone rings. I'm like, hello, I'm on my way to work. You lied on me, and you said I called you yesterday. That was literally how she was talking. I called you yesterday. I said, I talked to you. I didn't even know who I was talking to. I was like, this is so-and-so and so-and-so. And I didn't talk to you. Okay, so she's bipolar. Okay. So people don't, I know we on this call probably, well, I hope we all know what bipolar is, but bipolar is real. And I mean, and it's just what it is. So that's one. And then of course, another woman called me complaining, and this is what they do. I'm looking at a system. I can see that she's been provided all of these services. She's seen the doctor, she's seen therapists, she's got her assessments done. The community support worker's been meeting with her, and she's been meeting with the housing person, and she's bipolar. Now, I'm not a doctor. I promise you, if I go in the system right now, I'm going to see bipolar disorder, because she talked to me for about, I don't know, hour and a half straight nonstop. She complained the entire time, and she said she got no services and she doesn't know anything, nothing. But I can see in the system that people have contacted her and reached out to her. So you've got people on the one end, your customers, that are dealing with extended amount of stress due to COVID and all the things that you guys talked about, the stresses of life. And then you get the people on the other end that are trying to support these people. And some of them need medication, won't take medication. I'm sure I'm preaching to the choir, but it's the most interesting work. It really is. So burnout, I didn't take the test. I don't know what the numbers are.
Well, real quick, Denise, somebody asked, how much is it?
That was me.
Okay, yeah.
What's the question?
What's the cost for the patient?
What's the, do you guys take insurance? How is it covered?
Okay, so most patients are on Medicaid. And so are you asking for, so most of them are Medicaid, they do private insurances, but the therapists don't have to be licensed. Is that the question? No,
I'm asking because we're always looking for resources for our patients. If the less we have, the less the patient has to pay for it, the better the service.
So none of our patients really pay, because the majority of them are on Medicaid and what's called local dollars. So they have to be a DC resident. So that's the only thing about it, because the contract's in DC. So we take local dollars, but they've made us open up. They call them MCOs, which is private insurance, AmeriHealth, AmeriGroup, Care First, Beacon, Blue Cross Blue Shield, and a few others. We're an adult core, so that we don't have children. So we did not apply. We didn't panel with HSCSN yet. We will, but we just didn't. We didn't see the value in it right now. So yeah, we don't really get too many copays. We have a little bit under 600. We went from 60 to 600 in less than 11 months. No, I'm sorry, that's not even true. In like 9 months. So I don't know. Burnout. I don't even know.
Can you see what the pandemic has done to mental? Can you see what the pandemic has done to mental health?
Oh my goodness, it's heartbreaking.
I'd like to
go ahead.
Yeah, no, I was going to say I'd love to jump in on this one, because I think that's actually why I asked Anna to do that presentation. It was just sort of seeing, in terms of the impact of just prior to pandemic and the pandemic, the way the providers were working, and I say providers as a general term, everybody from the social workers to the physicians, nurses, et cetera, just on overdrive in terms of what kind of care we had to provide, pivoting to telemedicine, but also just even the angst of being there without knowing what your risk was for COVID, et cetera, but having to be present, and still people having their own problems at home with their kids at home, financial issues. We're sort of just starting to see this angst and people just sort of on edge. So had this webinar series and asked Anna to do this on burnout, highly attended, interactive, people just thinking they were depressed and then realized it was burnout or anxiety. And so I think identifying it is so key, because we don't really know what it is. Is it stress, is it burnout? And identifying is it, right? Naming it first, because at the extreme, we're talking about right now just people being, irritated with others, et cetera. But it's associated with accidents. It's associated with actual violence. It's associated with suicide. I mean, burnout can, at its extreme, be highly detrimental. In addition to lack of productivity and things that we talked about, where your organization doesn't just function the way it should, whether it's medical errors or people just not doing, or people who are really motivated, just getting by and not caring. You sort of, the Zoom camera's on and they're just like, whatever. That's actually dangerous too. So I think there's so many ways that it can be seen, but identifying, and I really do encourage everybody to take the quiz and be honest about it. I mean, 46, I feel like a 54, to be honest. I was surprised I only got a 46, right? And then saying, well, what is it that's causing me to be that way? And taking first the pressure off ourselves, because a lot of times we're functioning in a way that we think everybody expects us to be. And we're putting that pressure, and dialing back and getting by may actually be okay, right? We just need to get by. But I think these kinds of dialogues are so important, particularly in the Black community, where we do not talk about mental health. We don't talk about depression. We don't talk about burnout.
How could you?
Yeah, real quick. So for those who are just getting on, I gotta say shout out to my sponsor for my Wednesday show, the Old School Lunch Bag Mix. Sassy Frizzle Designs is on. We're talking about burnout in the second hour of the Love Lounge radio show, and we have Anna Kouoh, correct?
Yes.
Anna Kouoh,
Family
nurse practitioner, as the guest, and we're talking about burnout. We on digitalanalogradio.com's website. If you go to the website, right at the top, you'll see on the top, I guess it's a little bit to the left, is a little burnout test or quiz. Do it, please, and post your score, and Anna can help address what your numbers are on the score. But Anna, define the difference between burnout and depression, because they kind of seem to be a blurry line right there.
Yeah, I want to hear that one. I have no reason to be depressed at all. It's like,
so you have to think about so there's a DSM-5, which gives us your psychiatric diagnoses, and of course burnout isn't in there, right? But it just became like a disease. I think it was added this, and within the time of the pandemic, it was added into our medical processes as a disease process that can impact your health, right? Your health physically, emotionally, mentally, and all that stuff. But depression is, you have these cohort of symptoms. So, right, it could be not eating well, which are all the symptoms of burnout, but those have gone on for a long period of time, right? Without any changes based on your social circumstances. So your work has changed and your depressive symptoms have not, whatever the symptoms we've talked about in terms of burnout. So we've talked about loss of appetite, not eating or overeating, not sleeping or sleeping too much, these headaches, feeling on edge, feeling anxious. Those symptoms persist no matter what your circumstances are, right? So that would be the difference. In terms of burnout, if you offload and if you take a step back, do all of your coping mechanisms, so your self-care, taking time out to not putting so many hours in at work, taking time for yourself. Mm-hmm. Your symptoms of burnout will decrease, or the weight you feel because you're burned out from work will decrease. In depression, that will not change. Okay.
So like if you go on a vacation
No.
And, you know, depression won't change, but in burnout,
No.
you get it. You relieve
Exactly.
burnout.
And you're thinking about depression, telling somebody to take time off may not be the best idea either. So, right. So sending them on a vacation might be the worst idea.
Yeah.
Dr. Anton, could you add on to that, please?
Oh, yeah, I think that it's absolutely true. I mean, it's, you know, there's two key parts of depression that I typically look for. One is just what we call anhedonia, but it's the loss of pleasure, and loss of able to enjoy a meal, enjoy a song, enjoy a beach, whatever it may be. And that's exactly, you know, what Anna is talking about there in terms of, you know, you could tell a person, oh, you know, this is what you need to do, but at the same time, maybe that structure of the stress and them moving is what's keeping them moving. So if you take that away, that might be the worst thing to do in that scenario. So, you know, that loss of pleasure, you know, whatever it may be, that's a big sign. And then you also think about other ways, like, you know, do they feel like a good person? And a lot of people might just ask, you know, you feel like you're a good person? And people usually say, yeah, I do. But if you actually dig a little bit deeper, people start feeling a little bit more uncomfortable about their roles in life, their job,
or they may have that guilt. They feel guilty about even just being alive sometimes.
Yeah, I think one of the ways to start, what I used to do with patients, the first thing is ask them. Ask them, are you depressed? Okay, now we're all, like I said, we're Black folk, we're all depressed. You know, okay. No, are you depressed? Are you suicidal? Do you have a plan? You know, there's a series of questions. There's scales that clinicians can use to rank what a patient is feeling. And what I used to do, particularly when I was at Howard University, but then when I came to Hopkins, some of the clinics I was working, we had more support from social workers and the mental health people. But if I get a yes on a couple of answers, I had set up a good relationship in our HIV clinics at Howard with psychiatry. The chief of psychiatry at the time was very much interested in HIV, and many of the psychiatrists were. And, you know, when I start getting a couple of things, or, you know, patients start crying, and I'm like, okay, we're going to get a psychiatrist to come in, do an evaluation. That is not something that I play around with. But with providers, we have had, through this COVID, we have had physicians, nurses committing suicide. One of my colleagues at Case Western, we were working together on a project. He's a physician, Latino, very bright, up and coming. He headed up our clinical study, committed suicide. I talked to some of my colleagues up at Case West. They said they tried to intervene. I mean, I don't know all the details. I didn't want to dig too much and, you know, bring up, you know, hard feelings or pain or, you know, things of that sort. But
a lot of times the depressed or persons will be the ones who put up the best face for you.
Right. Yeah. No, so these things are important, and you know, again, with this being overwhelmed, or, you know, all of this type of stuff, it really impacts on, as Anna said very earlier, what are your outcomes? As Allison made reference to, errors being made. We have very precise work to do, making correct diagnoses, getting the complete history, prescribing doses of drugs. All of these things are very accurate. You have to have precision. You cannot be making errors. And our patients have so many needs. Everybody talks about, well, you know, you go see your physician, you know, you only have, you know, 10 minutes, or you have 7 minutes. You can't spend 7 or 10 minutes with these patients because their problems are complicated. And many of them involve mental health issues.
Dr. Anton, you wanted to say something regarding that.
Yeah. I mean, I think I don't know who's not on this panel here, but I assume there are other people who are not professionals. And I just wanted to make sure the message is also out there that you don't have to have a degree for this to be effective. It's important to ask no matter what.
Mm-hmm.
And it's been proven to be just as effective, even if you don't have a degree, don't have the training, just that connection and making sure a person cares. I'm just thinking of the time here. That's why I'm bringing this up, not to take down anything that Dr. Crawford said. He's absolutely right. But it's also very important that people ask if they're concerned, and don't feel afraid to ask, because it doesn't worsen the situation. It's always been shown to help.
So
And that was what Allison was mentioning about being aware of what it is that you're experiencing. That whole awareness thing is personal and organizational, because you being aware of what it is that you're experiencing and taking it to your organization, right? That organization needs to be aware that that is even a problem, to be able to put systems in place, put resources in place for you to make use of them.
So let me ask you this, Anna, because one of the things when it comes to us as Black people seeking help, I know, I opened up the show playing the song Superman by Black Coffee for a reason, because we have this Superman complex, especially Black men, beat my chest, okay, where we don't want to show vulnerabilities because it can come off as a sign of weakness. It can come off as unattractive to women, to our women. For black boys are told they're not even supposed to cry, even though you have tear ducts. They're told they're not supposed to cry when they fall and hurt their knee. Their mama or their daddy or others who call them a punk, quit being a punk. Get up, you ain't no little baby. So that starts at a very young age. 2-year-old, 3-year-olds, they fall and their knee is bleeding. They're crying. They're telling them to stop crying. Well, we grow up we manifest that into our adulthood, having this hyper masculine, persona that we carry about us, and this is amplified by the rap music industry, and everybody's got to be the biggest and the strongest and have the most powerful sexual prowess. All this exaggerations, but we're telling, y'all are telling, and I'm telling to people, people as well. It's okay to ask for help. It's okay to say, like Black still said, yo, I'm burnt out. What the heck? And we need to do that more often. But for those who do not know, if they came to you, Anna, say, I'm a patient, I'm this big, strong Black man, can handle anybody with my fist, know how to carry a whip, all of those things. And I come to you, say, yo, something's wrong with me, doc. Something's wrong with me. I'm burnt out. I don't know what to do. I'm stressed out, and I can't seem to perform in my daily tasks of life. What are you going to tell them?
I'm big on praising you for taking the step to come to me, because that in itself, you don't realize, or a lot of people don't realize, how much it took for you to make that step, right? Mm-hmm. I'm big on therapy will save you. Therapy will save you. Therapy will save you with issues you did not think you had. Or you can go and talk to someone about the happy things in your life, right? Because you may not have enough people around you who are praising you for the good things that are even happening, right? I'm going to applaud you for taking that step to come to me. And then, of course, as Dr. Antoine mentioned earlier, we need to look at what it is that you need, what it is that canvas. Look at that canvas. What it is that you are looking for. What is going to be help to you, right? And then what is your goal? What it is that you want to get out of this?
Okay, now Sassy,
and I saw. Sorry, go ahead.
No, I was gonna say Sassy. She put her score. She got a 49. Now she owns her own business, Sassy Frizzle Design. So, like I said, she's the sponsor of my Wednesday show, and she's been grinding. And she was also saying, the Black women also carry that persona as well, and they do, because a lot of times they can't come off as weak, because especially depending on when you're working out in that field, because it's like, here we go, because she's a woman, she can't handle the workload, or she can't handle the emotional load that it takes to be a boss or to be a leader example. So what do you say about that?
Allison mentioned earlier that sometimes you don't have to do everything. You don't have to do everything. I know that we come from generations where we were taught to reach for the moon, and of course reach for the moon, but don't reach for 5 of them, right? Don't reach for 5 of them all at once. I want I want you to be successful in 1, 2 things that you do. I've been seeing a lot lately that has to do with get your stimulus money and start a business. Not everyone can, not everyone,
Right. Yeah.
that's not the goal for everybody, right? And just because I don't want that goal doesn't mean that I'm any less than someone who wants that to be a goal, right? It's okay to take a step back. You're not a failure for taking a step back.
Now, one last one, because we're going to be wrapping up, is that we've seen just recent numbers have shown that divorces have gone up a lot since COVID, and a lot of that has to do with people, having to stay in the same house and social distancing from everyone, and so we've seen the divorce rate for everyone, not just Black people, but for human beings, rise up. So, any advice to the people, because this basically this spouse burnout now thing that we're seeing, because you
spending too much time together, or they've gotten time to talk about the issues that they were avoiding by going to work.
Right. Just you might love them, but you be like, sometimes I just don't want to see your face, but I'm being real about it, but that's what when I was reading about it, as some of the people were saying, it's like it's different when you get some time apart from each other. So what should they do real quick to help combat that?
Well, we've talked a lot about, so now we're getting into how do you combat burnout, right?
Right.
That awareness, knowing that what it is, being able to differentiate emotions it keeps you in control. I don't know. I'm echoing. I don't know. I'm not sure if that's just me.
You're good.
Okay. Okay. Being able to identify your emotions gives you so much self-control, right? Because you're able to identify what it is that's causing the emotion, what the consequence of the emotion is. It could be negative, it could be positive, right? Taking time, self-care time is so important. And the other thing that I want to stress on that I don't think that, I think it's mentioned and we're like, yeah, meditate. Yeah, sure. I'll do it. It is so important to get your body into that rest and digest, that parasympathetic nervous system, to get it activated and get it doing things. Meditation, I know that a lot of us don't know how to do it. Start out with 1 minute on YouTube, 1 minute, and you'll notice over time, you're going to bring your heart rate down. You're going to bring your blood pressure down if that's an issue. You're going to wake up and just be grounded from if you're starting out your day and ending out your day. And that way you're going to be grounded. I worked in chronic pain. We've talked about in our Black community, there's a lot of pain. It could be emotional pain. It could be physical pain, right? Biofeedback. And we don't have time to go into exactly what biofeedback is. Essentially getting your breath, focusing your mind into whatever the ailment is and getting your breaths aligned with it so that you can dissipate the pain. Okay. It could be mental pain. It could be physical pain, whatever it is. And there are plenty of apps out there that will provide you with that. There's the Calm app. A lot of institutions are providing you access to that for free, where you can practice meditation there. You can practice meditation there. I think you've seen the commercials. They come on your TV.
Yeah, I've seen the commercials.
LeBron James.
There you go. 1 minute. Stop. Do nothing.
Dr. Agu, you wanted to add something real quick?
Yeah, no, one, I wanted to mention that there's Shine, which is an app that's specifically targeted at Black people, people of color. But the other thing I wanted to say, and I think the personal things that you can do are really important. I think setting limits. I think there's been this bleed of time where the emails go all evening, the meetings continue to stretch, and setting boundaries and protecting your space is so important. Don't be afraid to shut off. You can actually, there are features on your email and things that you can literally shut off so you don't get an email between this time and that time that can actually protect your space. And so there are apps that you can actually monitor how much time you actually spend answering emails, when you answer emails, and you'll see we're doing things all day. So protecting your space and then blocking out time to exercise, to do whatever, or just to do nothing and being okay and not apologizing for it. This is the whole work-life balance piece of it.
Now,
Absolutely.
Dr. Antoine, because for me, I learned to eat certain foods that help. Exercise and going to the gym. But then one of my problems was because of COVID, I was scared as hell to go to the gym for a long time. I ain't gonna lie. And then it started to bother me though, because it was fine in the summer. Me and you, we were doing bike rides and things like that. But then when it got cold, I'm not out there riding no bike, in 40 and 30 degree weather. But what are some without prescription, what are some things that people can put in their body? I drink a lot of water to help, but what are your recommendations that, any type of foods or even over the counter stuff? Because I know I bought some stress thing. It was some type of berry gummy thing, and it actually helps calm me down every once in a while when I need that.
I mean, I think the stress and things all go back to the brain, and the brain needs the same nutrients it needs every single day. So I would say it's an opportunity, not necessarily to get anything special, because that's going to be extra money, especially during this time. That might be tough for certain folks. But I would say it's a good opportunity to make sure there's a good routine that has options. So different options of how to eat healthy, a good balance of nutrition, whether it's vegetables and then, not heavy meals every day. But I think it's a good opportunity to keep the basics, because as people try to get all these new things and these special things, that is stress too. That's a hidden stress. And I would say keeping it simple, but keeping it consistent and keeping it as healthy as you can, because nothing's going to be perfect right now. I remember a time where I was worried to get out to the grocery store. Mm-hmm. And so I think that's the caveat I would put on that, is to say, make sure it's consistent. And, it's a good opportunity maybe to read up on a couple of things and add things gradually that could be healthy. But I think it's just a good opportunity to say, like you're talking about, water, important. Vegetables to balance out, important. Making sure there's some fiber in there, important. And keeping up with the, balance of activities like exercise, a few hours a week total, not like the 2-hour stretches like we used to do when we were 16 or whatever it might be, but, flattening that curve, making it sustainable, but something that is still workable for folks.
So for the workaholic, so for someone like DJ Black Steel or Sassy Frizzle or Mod X, would they, because they have to work, mm-hmm. they have to do things or it doesn't get done, is which that's one of the stresses. How can they break these things up without losing productivity?
Well, I think that's a conversation. Sometimes, I don't have a child. I'll say that up front. I know that's why I'm probably at the lower end on my 32 versus a 46 or whatever it may be. But I think it's a conversation sometimes with the people that, you can have that conversation with. I've had a conversation with a few of my colleagues and saying, the goals that you have are not reasonable. And we need to restructure that to make sure it is reasonable. And making sure people aren't placing expectations on you without stating them and having a conversation about them. And it's identifying those places where it's possible. And then if it's not possible in other places, it's finding a way, we often say sublimate, but it's really to let go of that energy that might be brought in from those other places that it's put onto you, and recognizing when people are projecting things onto you, because that's a big part of it. So I'm not saying that every single situation you're going to be able to restructure, but if you can, identify which ones are in your control versus out of your control, that gives you a running start.
So Anna, and I'm looking at the chat group, and Sassy says she's drowning, and I know she is, because her company is new and she's got to put out in order, and she does amazing work. First of all, let me say that. But in order to do amazing work, you got to put in amazing time. And Mod X is saying she's doing the same thing. She's putting in 13 to 16-hour days. So what do you have to answer for that?
It's not what she's going to want to hear, but you have to put in that time to take yourself away from it so that you can reset and come back and give it your best. It's unfair to have to step away from something you love, right? But in order for that love to get everything that it possibly can from you, you have to recharge. And that recharge might be, like Allison said, lay in bed and do nothing.
Mm-hmm.
I know that she might not be able to turn off her mind, but that's where that meditation comes in. You put in that 5-minute YouTube or something, put in that 5 minutes, turn your mind off. And it doesn't have to be a whole day that she's taking off, just an hour. So you're not doing that work, an hour, 30 minutes, 20 minutes.
Yeah. All right. Well, we going, speaking of minutes, we going over minutes on the show. It's past 10 o'clock. So we got to start wrapping up. My producers are letting me know that. But I want to thank you, Anna, and everybody else, Dr. Antoine, Dr. Aggie, Dr. Crawford, Denise. I want to thank Dr. Milhouse as well. Thank DJ Jimmy Fingers and DJ Black Steel and Mod X and the rest of the Twitch squad. And catch you all next week. Check me out tomorrow for my show, the old school lunch bag mix at noon on digitalanalogradio.com. And take a break, listen to some Lettucey, take some time to yourself. You know,
Yes.
We're gonna have to do a part 2 on this. May is Mental Health Awareness Month. We might have to bring everybody back for that one if that's cool with y'all. But
Dr. Antoine has to come back.
Yes. All of y'all. So thank you, everybody, and I'll see you all next week. We're out of here. Peace.
Thank you.
You wanna find a place to escape. It's your life. You gotta do whatever it takes. Yeah. Take some time. Get away.